what we're going to get into today is talking about how myths and misconceptions and other misperceptions about substance use create barriers, create stigma about addiction. But what I'm going to show you here today is how we can combat that. And literally, I'm going to give you tools. I'm going to give you a fascinating case example of how I went with one client who was extremely resistant to even addressing his substance use to becoming motivated. And I'm going to suggest that it was all about changing how we talk about substance use and making sure that we're informed. And so that goes for clients that we're working with. It goes for families of the clients, making sure that they're informed. And it also goes for professionals, making sure that professionals are informed on the implications of what it means to be diagnosed with a substance use disorder. You see, I had a little trouble packing all that into a title, but some of the, like I said, some of the promotional stuff that I started writing after I put this title out, I was saying, change the conversation. How to, addressing the stigma of addiction and moving from shame and stigma to validation and hope for recovery. That's what we're going to be talking about today. But as you'll see, and as I share my background, I have spent my career working with younger people in treatment. And as I said, that implies earlier stage substance use. There's a difference between assessing early stage substance use and late stage substance use. I didn't even really start appreciating or recognizing that until sort of relatively recently. Wait a second, all the people that I'm working with are early stage. And I was saying that in the context of some of the concerns that I see, some of the problems that I see in our field, as far as letting substance use issues slip through the cracks. I started recognizing some of these specific problems I want to address. They actually are respective to early stage substance use. So that's a little bit of an introduction. Let me pull up my slides here to officially start this. Give me a second here. There we go. If I haven't had the pleasure of meeting you yet, my name is Jim Savage. I'm a licensed drug and alcohol counselor. I see Katie is here from Texas. I have a hunch I sort of know who you are and what program you work with. I see you on LinkedIn or in Facebook or someplace. I think I see you around. I think I know what program you're with, and I appreciate you being here. I just moved to Connecticut 2 years ago. My majority of my career is in Texas. I'm going to be talking a lot about work that I did in Texas here today. I've been working in the addiction treatment field for a really long time. I started off in the mid 80s. As I said, I had a little hiatus when I relapsed and went to treatment myself. And so how long I've been working in the field, I never know exactly how to say, but suffice it to say, I've been working a long time. From 2000 to 2010, I owned my own adolescent IOP program that was in Texas. Learned a lot of the work that I do today was informed by what I learned from that experience of running an outpatient treatment program. I sold that. I opened my own, went into private practice. I wrote a book after working and running that program. I decided to work with families. And so I wrote a book called A Parent's Guide, Rehab Works, A Parent's Guide to Drug Treatment. And I ended up developing an entire family support program based on that book. And I've been really focusing in the last 10, 15 years on parent support in treatment. And I have an entire online education program that I license to treatment programs. I do family coaching myself. Big news today is I'm actually writing a revision to Rehab Works. I wrote it, it was published in 2014. And one of the things we're going to be talking about today is the evolution that our treatment, addiction treatment field is constantly evolving. And even in the short time since I wrote that book, some things have changed that I've known. I haven't been pushing my book too much because I've known I need to go back in there and do some revisions. And I'm actually sat down and started doing that recently. And so I'm going to have a 2025 revision coming out of Rehab Works. And the bottom line is it's going to be the new things that I'm putting in there are what I'm going to be presenting here today, a lot of that. And so, and as I said, the main thing that I do today is I'm in private practice. I do assessments and interventions with young people, and I send people to treatment, or I work individually supporting recovery. And as I said, I also do family coaching. I work with parents and I do interventions and case management and continue to work with the families while the loved one's in treatment. So let's see here. I'm going to start off talking about the idea of assessment. Oh, no, that's not the clock management. We're going to talk about assessment, as it says here, and just a few short comments about the concept of substance use assessment. Then I'm going to talk about creating motivation. I'm a big advocate and focus on the word motivation, because when it comes down to it, motivation is really all that matters, right? As far as a client's success or lack of success, it's going to be about their motivation. I've got some comments I'm going to make about how to create motivation for clients. Then we're going to get into talking about the misconceptions and barriers to treatment, as I alluded to earlier. And I'm going to present this case study that was a eye-opener for me about these topics like stigma of addiction. I saw first hand how that happens, what creates stigma in addiction, stigma around addiction, but I also saw how to change that. And I'm gonna go through that with you. And I think it's a powerful example that I'll be sharing with you. And then finally, I'm going to talk about our responsible substance use disorder management. I'm going to talk about concerns that I've had in recent years about watching cases of where substance use is there and allowed to slip through the cracks. And that's sort of what I'm on a bit of a soapbox about these days, is wanting to make sure that everybody's on the same page as far as understanding what it means to be diagnosed with a substance use disorder, and the implications that holds for treatment. And then at the end, I'll stay on and take questions. I'll invite you to type questions in the comments while we're going today. I will tell you that I may not address them while I'm talking, because I know myself well enough that when I start talking about a question, I can go off on tangents, and I want to make sure that I get all our material that I have prepared here in. And so I'll be glancing at your comments or questions. And again, I would also love to see comments on your experiences on some of the things that I'm talking about and what some of your thoughts are on that. And if you stay on to the end, it says here, free PDF, 5 Steps to Family Recovery, just 2 minutes before we came on. I've got a different free ebook that I don't put out very much, but it's called What's the Problem? And it's all the stuff. It's sort of what was the impetus of this presentation. I'm presenting all the stuff that's in this little short ebook that I wrote called What's the Problem? And again, full transparency. The reason I wrote that book is when I sort of had one too many phone calls from parents calling me after they'd had a bad experience in some sort of mental health services where substance use didn't get addressed appropriately, and it came back to rear its ugly head. And so one day after hanging up from one mother, I thought, you know what, I'm going to write a book. And I wrote about a bunch of these examples, and I explained what I'm going to present there. So I switched the link that I'm going to give you. If you want to get that ebook, I'll give you a link to that ebook called What's the Problem? That's a summation of what I'm presenting here today. Okay, so let's dive in. I'm going to try to go through some of this stuff in the beginning relatively quickly. I don't do anything quickly when it comes to speaking. You'll see we've already gone 15 minutes, and I should have started this 10 minutes ago. But I want to get in, save time for the meat of this stuff. But so first of all, let's talk about substance use assessment. And my main point that I want to stress here is, I could put it this way. Years ago, I came up with some little thing. I created some content back before creating content was a thing. I probably created this before Instagram existed, but I came up with this little thing I called 5 things every parent should know about substance use, teen substance use. And I had 5 points. And the first one was, when in doubt, rule it out. And the implication there, the suggestion there is, if there's substance use, if we become aware of substance use, regardless of how limited it is, it doesn't hurt to check out if there's something going on. When in doubt, rule it out, get an assessment. And as you see, that second bullet point I put there, getting an assessment is not an indictment. I think there's already stigma there. Parents are afraid, in some cases, of maybe suggesting to their child, we want you to go have a substance use assessment. Or they could have their own shame. I can't even believe we're in this arena of having to talk about mental health professionals intervening substance use assessment. But the fact is, even if it's first time the parents catch somebody using, it doesn't hurt. There's nothing wrong with going through, and then we'll talk for a second about what a substance use assessment is. It's a formal procedure done by a professional, a substance use professional who's trained to do assessment. And the fact is, if there's not, watch this, I'm going to say air quotes, around the word problem. You'll see, I'm going to say that all through this. I use quotes a lot because a lot of what we're going to talk about, the problems that we have, is centered around terminology. And the word problem is at ground zero of where problems spring from, because everybody has their own idea or definition of what the term problem means. And I use that for convenience sake, but I'm always saying quote unquote problem. But so like in this example, is if a family, we see substance use has happened. Okay, well, we're not saying that you have a problem. We just want to make sure that there isn't one. And there was another point of my 5 things every parents should know. The second point was what I called the 1 in 10 rule. And I'd say, for every one thing you know, there's 10 things you don't know. And usually when I share that with parents, they start nodding. They get that resonates with them. And so lots of times the amount of use that's been going on it's more common for it to be more than the family is used to, right? And so you just want to make sure, and a responsible trained substance use professional can't make up a problem. We can't, so the client who's resistant, you can tell them, hey, if you don't have a problem, which they may be well poised to want to make the case that they don't have a problem, this is your chance to present your case. And if you don't have a problem, you're going to get the formal declaration you don't have a problem. And if a person doesn't have a problem, there's no problem. And so that's the first thing that I just try to stress is sometimes people are going to be afraid. Hi, Jackie. People are going to be afraid of just broaching the issue. Sometimes parents dance around the issue and avoid that. So first thing I say is we want to go ahead and err on the safe side. Technically, what is a substance use assessment? There's two main factors, but the important thing is that it's being done by a trained substance use professional. And there's tests that people can take that are scores, like SASSI's. That SASSI it's very reliable, but it doesn't take into account into nuances. And so, for example, a SASSI test can provide a score, and there's one factor can say high probability of substance use disorder. Okay, well, just that doesn't tell us what recommendation we need to make as far as where we should go with that. The second part of assessment is the psychosocial interview. And that's where you ask the client about everything else in their life. And it's the process of pulling that together. Do you have any mental health? We do a mental health examination. Do you take any medications, psychotropic medications? Tell us about your family situation, your living situation, relationships in your family. Tell us about your work or your school progress, where you're at, what that situation is. Tell us about your social life, all that type of thing. When I'm doing substance use assessments, I sort of save the asking about the substance use till much later, because there's also sort of some gamesmanship going because of this high probability of defensiveness in this situation. And I sort of nonchalantly towards the end, I've been trying to build rapport with the client first before, and then I don't say, so have you ever smoked pot? I don't say it that way. I just naturally say, so when was the first time you smoked weed? And sort of disarming them. Well, it was the first time. But the point is, we want to get a thorough substance use history on them. But again, the point that I want to make here is an assessment is gathering information. It's not a counseling session, but we can, based on the information that we get from the assessment, make a diagnosis. And from diagnosis, in theory, we can, on paper, X's and O's, black and white, we can sort of follow charts as start, if they have this, if this is going on, this sounds like somebody who needs to go to residential treatment. If this is going on, you might need to go to intensive outpatient treatment. This one, I think you'd maybe benefit from just outpatient counseling, or we could end up saying, I don't know why they brought you here. There's no substance use problem. Okay, this other behavior might need to be addressed, but it's not in the substance use. So we can make a recommendation at the end of assessment, but let me see what my next slide is. Here's an important part. What do we do with that? I can tell a client, based on the information that I get from assessment, you need to go to residential drug treatment. And I can give the family the names of 3 places for them to go and say, good luck. And the fact is, all you have is a pissed off client, some parents not knowing what to do with with this person. And if they do get them into treatment, you might waste the first 3 weeks of treatment arguing with the client about why they're there. And so that brings up the topic, a word that I am very keyed in on, and that's motivation. How do we motivate clients to want to change? And I've done a lot of work over the years in developing specific ways of making that happen. And to open a conversation on motivation, I'm going to take a quick second to introduce to you, if you're not familiar with the stages of change. I know some of you, I'm sure, are familiar. I'm a big fan of the stages of change. It's an integral part of the work that I do as treatment clients, but I'm going to use it here just to show where this motivation fits in a recovery process. But so to do this, I'm going to go really quick. The stages of change are a series of stages someone's going to go through anytime they make a decision to change a problematic behavior. So the first stage is the pre-contemplation stage. That's the denial stage. A problem exists. They're not aware that the problem exists. Second stage is the contemplation stage. That's when we begin to look at the behavior and make a determination. Is this a problem? Check yes or check no. Then the third stage is the preparation stage. If we do believe it's a problem, we develop a plan to overcome the problem. The fourth stage is the action stage. We begin to practice new behaviors to carry out the plan. And then the fifth stage is my little note here, 3 to 6 months. The action stage should last 3 to 6 months, a lot longer than most people might be aware of, because we have to take long enough for those new behaviors to become routine. And then eventually they're going to move into the maintenance stage, which is characterized by consistent symptom-free behavior. That's my quick thing. I do a lot of work with the stages of change, but I'm just going to show you that because we're going to go back to the contemplation stage. And this is the only place in this entire process where motivation occurs. It's in the contemplation stage. And by that, I mean, the truth is, it's not really that hard to get a client to admit that their substance use is a problem. Yeah, I guess it is a problem. And if we don't tap the brakes and make sure that they understand what that means, lots of times, and raise your hand, type a 1 in the chat if you can relate to this. We end up in power struggles with them later on because they're not following the plan. And sometimes, we're banging our heads against the wall and we're picking the wrong battle, or we're looking at the wrong area to figure out, well, why aren't you going to your meetings, or why aren't you blah, 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 whatever. And we need to back it up. If they don't really believe they have a problem, but really what I mean by that, ask the second question. Like I said, it's not that hard to get somebody to say, yes, my substance use is a problem. I say, ask the second question. What does that mean? And that's where understanding the characteristics of what it means to be diagnosed with a substance use disorder, if they have a full respect of those things, I'm going to show you what I mean here in a second. That's what's going to create the motivation. If we're treating a diabetes patient, you have diabetes, you need to take insulin every day, and whatever diabetics have to do, watch what you eat, read the labels on the food that you eat, etc. Learn how to measure your blood sugar. You have to do that. If they don't understand why they have to do that, they may not be as motivated, as opposed to the doctor might have to say, okay, here's what the deal is. Your pancreas doesn't produce insulin the way that it's supposed to. And here's what happens when your body doesn't get the insulin. I'm not an expert in diabetes. Forgive me if I'm not saying this exactly right. But the point is, I go, oh, okay, I guess I have to do this. It's the same thing with helping a client understand what it means to be diagnosed with a substance use disorder. That's what's going to motivate them. And to the converse, lots of times when they're not doing what they need to do, when they're not following treatment recommendations, it's a case of not being motivated, and it often stems from problems in the contemplation work. And so what ended up happening when I was running my IOP treatment program, and I would do assessments, and at that time, we would do free assessments because it was whether somebody's going to come into treatment there or not. And I could get the information. You can take it 45 minutes to go through my interview with them and get all the information and not care about, creating rapport with the client or what, what I ended up finding is I had trouble just taking the information, telling the client, okay, you need to go to treatment without helping them understand why. And I would end up taking longer and longer. My assessments one day, my office manager said, Jim, you can't take 3 hours doing an assessment. We weren't getting paid for it. And it was taking up 3 hours of my time during the day. And that's valuable time or whatever. But I found myself just doing what comes natural. I would want to help the client understand why I was getting ready to tell them you need to go to treatment or something. And so I would do this crash course on what it means to have a substance use disorder. I'd try to cram it all into assessments, and it would end up taking a long time. I eventually sold my treatment program, went into private practice, and I had the luxury then of being able to extend this process. I might do the assessment and I'd say, can you see why maybe we need to have another couple conversations about this? And I'd have them come back, and over the course of a couple of years, I sort of honed this process of extending the assessment, doing a little bit more intensive look, but also teaching them what it means to have a problem, what the difference is between social use and problematic use. And I eventually, decide one day, well, I'm going to do a little branding marketing thing. I'll put a name to this little 5-session program that I do. I call it Prevent. And I've been doing it for years. I'll do an assessment with somebody. I'll say, can you see that we should, this warrants a little bit more of a conversation? Yeah, I can see that. Okay, you're going to come back. And so my Prevent process, I start off doing a session with the client and the family. And it's a pure educational, what it means to have a problem versus what social use is. Make sure everybody's on the same page. And then I do 3 individual sessions with the client where I have them do a bunch of written work that's all contemplation work, weighing the benefits versus the risks of continuing to use, identifying with characteristics of substance use or symptoms of substance use, seeing it for themselves. Where has my use got me versus where I want to be in various life areas? Where is my motivation coming from? Am I externally motivated? Am I internally motivated? That's all contemplation, helping them arrive at a decision. Do I believe this is a problem or not? And then the value of that also is over a period of time, you're able to identify their defense mechanisms and, or how defended they are or how open they are to, accepting, the information that they're giving. I'm often able to, this is how I do an intervention, is by the 5th session where we meet again with the families, I have the client go over with the family what we've been talking about, and they're usually telling the family, I need to go to treatment because I've helped them see that. And that's what I mean by a motivational approach to intervention. Or if they're not, I'm able to work with the family and say, you know what, we gave them as best shot as we could, and they're dug in denial, and they've heard it all, and you've heard it all, why they need to go to treatment. And even if they're going to disagree with that, now we work with the families on setting boundaries and, develop a different plan for taking action on getting them into treatment. So I'm going to switch gears here now, and I'm going to give you an example of one case that I was doing with a client. What are you telling them in the crash course? You're gonna see some of this right now. So I had a client referred to me. The mother called me, and he was referred by the psychiatrist, and she said to me, he doesn't want to see you. And I said, yeah, okay, I'm pretty used to that. Nobody wants to see me. And she made an interesting comment. She said, he's just going to tell me I'm a bad person. And I thought, okay, that's interesting. Um, but I just sort of let that go and did the assessment with him, suggested we go through prevent. And so in the first session of prevent, this is the educational piece. I begin teaching them, okay, let's talk about what it means to be diagnosed with a substance use disorder. And I should say that I'll back this up and say he'd been seeing an outpatient therapist for a year, and he'd been continuing to smoke pot throughout that. And the parents went to the psychiatrist and said, we don't feel like that we're making any progress with this outpatient therapist. And that's when the psychiatrist said, go see Jim. And so that's how we got to that. And so in our educational piece, I begin by putting up this slide. And now I'm talking to the kid and to the parents. And I say, most people have an idea of a line that you cross over when it comes to addiction, right? And I say, right? And they all nod. And I will submit that at the moment, when I did this with this family, both of them nod, the kid and the parents. I'll submit that at that moment, the kid is thinking, that's right. There's a line that you cross over, and I haven't crossed over it yet. And I'm going to suggest that the parents are thinking, that's right. There's a line that you cross over, and we're praying that he hasn't crossed over that yet. I'm guessing that that's what they're thinking. And I say, I do mention that this is, how we used to diagnose substance use disorder is this line. And on one side, we called it, there was a diagnosis called substance abuse. And on the other side, substance dependence. And I would say that substance dependence was synonymous with what we would, here's another one of those quote unquote ones, what we would identify as addiction. But even now off the reason the quotes, even the term addiction is a problematic term. I'm using it right now. And while I'm talking to those families, I'm talking with things that they're familiar with. But really what I'm doing is I'm playing into the misconceptions at this point. But you're going to see where I go with this. And I say it used to be that this substance dependence diagnosis meant the same thing as the disease of addiction. You've crossed over the line, once an addict, always an addict, no going back, have to go to recovery meetings for the rest of your life. And again, people get that. The families are, both are saying, I sure hope I haven't crossed that line. I don't think that I'm there. We hope he hasn't crossed that line. But I just let them sit with that for a second. And I go on. Well, and I should say this. And on the substance abuse side, that's actually a diagnosis. There's a difference between not meeting any criteria for a diagnosis. There is no quote unquote problem. There's no issue at all here. But some people could have a diagnosis of substance abuse, but that means they haven't, back the way that we used to look at this, crossed over the line. And as it says on that slide, the implication there is they may grow out of it. Some education or therapy may be indicated. Okay. And so they might be thinking, yeah, that may be where I am. I'd be okay with that. But I just go on them and I say, a little bit further into explaining addiction, what we're thinking about on that right-hand side of the line, that there are characteristics of addiction. It's a primary condition. That means nothing else caused it. It was the actual drug use that caused changes in the brain that resulted in that term at the bottom there, loss of control. That's what addiction is, but nothing else caused it. And if I continue to use, though, nothing, other problems in other problem areas can be effectively addressed until I arrest the primary problem. It's progressive. It means it has a tendency to continue to get worse. Chronic means it lasts a long time. I'm saying this Now today, even though I'm not, what you see I'm doing here, I'm talking in old terms. Today we'll say it does, that's there's no cure. That's sort of an archaic way of saying that today, that once an addict, always an addict. That's archaic, but chronic technically means a medical condition that lasts technically longer than 3 months. And the point on the chronic here is that it doesn't automatically go away with them admitting I have a problem. Okay, I admit I have a problem, I'll stop. Lots of times they're thinking that fixed the problem. And there's a big loophole or a crack in a foundation by that misguided thinking, because, okay, I submitted, I admit it, I got a problem, I'll stop. And they may even mean it, but they might not realize that their brain hasn't changed back just because they admitted it. And that's where the importance of understanding chronic is. Potentially fatal. There's a ASAM definition of addiction that says addiction is progressive, and without treatment or engagement in recovery activities, addiction is progressive and will lead to premature disability and premature death. Okay, we all get it. There are ways that substance use can kill, and we sort of never know when that could happen. And the loss of control has to do with the rewiring of the brain as the direct result of continued substance use. And the rewiring, I use the term in my program, in my Rehab Works program, the party voices get louder than the not a good idea voices. And when the party voices are louder than the not a good idea voices, the person ends up using, even though they told themselves that they weren't going to do it. And so that's the loss of control. That's a characteristic of addiction, or is associated with addiction. So what I'm doing while I'm presenting this, or I was doing this with a client, this is one of the first times that I did it this way, that I literally set this up in our old way of thinking. And I know that by this time, they're all thinking, yes, okay, it looks like I'm doing a scared straight thing. If you haven't crossed over that line, you don't want to go there. That's probably what they're thinking. Man, I wouldn't want to be in that situation, have progressive chronic loss of control. That sounds like it would be really bad. And so maybe I'm being effective in scaring them straight. But then here's the kicker. Then all of a sudden I said to this family, now, one more thing I got to tell you. Everything I just told you about how we diagnose addiction is wrong. And I let them sit for a second, and they're like, what's he talking about? And then I have to tell them about, some of you might be familiar with this, the evolving addiction field, and how we diagnose substance use disorder gets determined by this book called the DSM, right? And the DSM continues to put out revisions every few years. And everything that I just showed about the substance abuse and substance dependence dichotomy, black and white line that you crossed over, that all got blown up when DSM-5 came out in 2013. They completely turned over the diagnostic framework for how we diagnose substance use disorder. And what it in effect did is it took away the terms substance abuse and substance dependence, took that line out, and made it all one condition that we call substance use disorder, with classifications of mild, moderate, and severe. And I throw in here at this point, the reason I'm so hypersensitive to this difference between the old model and the new model is because I had been spending a year and a half writing my book, Rehab Works, and it was ready to come out from the printers the week that the DSM-5 came out. And the first half of my book, Rehab Works, was explaining how we diagnose substance use disorder per the DSM 4. The day the DSM 5 came out, it made my book that was just about to come out from the publishers totally obsolete. And not to mention having to go back to the drawing board. And this was such a drastic change for us old drug counselors. We were like, wait, where is addiction fit in this anymore? And there was some very challenging questions that the DSM-5 created. And I had to spend another year studying. I interviewed the doctors that are involved with the DSM. I was talking to leading people around the country, asking questions about how to explain this new framework. And like I said, some of the glaring questions that it left. So I've spent a lot of time focused on this difference between the two. And at the time that I finally got the book out, one of the things that I'm putting in this revision book now is there were still some things that I didn't say. I just got myself good enough being able to explain the new. I said, this is a brand new way of, we just went through this change. I mentioned DSM-5 came out and now it's new, but I didn't really go into detail about how much I didn't understand about the implications of the new framework. And we were, at the time that I rewrote that in 2014, I was still not comfortable. I wasn't settled, with this new framework. I didn't say any of that in the book, but now in my revision that I'm going to put out, I'm going to say that over the last 10 years, I have evolved also in terms of understanding. And it's sort of because of my unique experience of having to focus on this so much, and I use this so much in teaching, that I've actually turned it into a positive, which I'm showing you right now. Because go back to sitting there with this family, and I say, everything I just told you is wrong. They were all set up to the black and white dichotomy, line that we cross over. And I think a lot of people, that's one of the main points that I want to stress here today, is we have this image of a line that you cross over, and we think that we haven't crossed over. Or the other thing is if we haven't crossed over, here's my biggest concern. I think that there's a conception that it means not having a problem if you haven't crossed over the line. Those two things are exclusive, or what am I trying to say? Mutually, they don't match up with each other. And that's what the new model says. You can have a disorder, but it doesn't mean you're on the severe end and that you're what they're thinking, quote unquote, addiction. And the couple of things that really made it hard for us to understand, one of the pieces of information that I came up with when I was studying this, I read a piece of research that said we see higher relapse rates with substance abuse patients than with substance dependence patients. And when I read that, I didn't understand what that meant. That didn't make sense to me. And the reason it wasn't because I was thinking, okay, they're not as severe, why would they be more prone to relapse? It's not that. It was that with substance abuse patients, we didn't regard it as serious, and we didn't develop treatment plans to manage it. And so we just slap on the wrist, make better choices, maybe go through an alcohol education class for a weekend or something like that, and that's it. And then say, okay, don't use anymore. And we leave it at that. And this one piece of research, and again, this is before DSM-5 that this research came out, that evidently people that have a substance abuse diagnosis continue to use more than people with a substance dependence. But that's simply because with substance dependence diagnosis, those are the people that are addicted, and they had to go to treatment, and we developed treatment plans, very specific and stringent, and relapse prevention plans. And if they used again, they had a sobriety date, and they had to go back and start over counting days and such. And those people relapse less because the focus was on there. We just didn't develop treatment plans for abuse patients. And that was an interesting thing. But then the other thing that really threw us for a loop is that they said that all those characteristics of addiction, um, the chronic progressive loss of control that we used to reserve for, that's addiction. You're down on the severe end. They said anybody with a substance use, even in the mild category, is vulnerable or susceptible to experiencing those characteristics. That's the kind of thing that I mean when I say that didn't make sense to us. It was like, to me, loss of control, that is addiction. And someone with a mild or substance abuse, if they haven't crossed into, again, quote unquote, this is our old thinking, full blown addiction, whatever that means. But, if they experience loss of control, that is addiction. It finally started to dawn on me that, you know what? There's a lot of clients I've worked with. Remember, I said at the beginning, working with early stage clients is totally different than working with someone who's been drinking for 40 years and they've been through treatment 3 times and they've got a new liver and that's blown up also. That's, when you see it, that looks like full blown addiction. But someone who's only been using a few years, they may have a disorder, but they sure haven't progressed into what would warrant enough a diagnosis of severe. And that's especially true with cannabis users because cannabis doesn't produce the same kind of severe consequences. And that's, I got to throw that, severe that's a nuanced thing. Cannabis use sure can produce consequences, but they appear more subtle. The functioning addict, quote unquote. But I started realizing, wait a second, there's a lot of clients over the years that I've worked with that are definitely not down at the severe end, but I could give them an assignment to write me 3 examples of times that you used when you told yourself you weren't going to do that. And they could do that. And I started realizing, well, I guess that is loss of control. And I started realizing, and so, for example, this case that I was working with, I said to this guy, I said, you've been struggling with this marijuana issue for what? How long? When was the first time you got intervened on or trouble? Over a year ago. Okay, so this has been an ongoing problem, longer than 3 months, right? He admitted that he was trying to cut down his use. And I said, could you have there been times you told yourself you weren't going to use and you did? He goes, yeah. I said, okay, you got loss of control. Have you been dealing with this for, longer, than 3 months? Yeah, I've been doing it for, okay, it's not going away. Has it continued to get worse? Has your pattern of use progressed? Yes, it has. And so he was able to see that he did be able to relate to those characteristics of full-blown addiction. But what I ended up saying to him then, to sort of sum this up, I said, your mom told me before you came here that you weren't thrilled about seeing me and that you thought I was going to say you were a bad person. And here's what I'm going to suggest is going on in your head. And I said, 1, I think you know that your substance use in this drug of choice, cannabis here, is a problem, that that there's something not right about your substance use. And he said, yes. And then I said, I also think that you think that you're not addicted to it. And he said, yes. And I said, I think you're right on both counts. And he was like, okay. And you can see that you have a disorder, but this helps you see that, again, the reason you're resistant is because you haven't crossed over that line. And you're sure that the drug counselor is going to be tunnel visioned and just going to say, you've crossed over the line, you're an addict, and you got to go off to treatment. And when I showed him this stuff, and when I said, you know what, you have a disorder, and he had given examples of trying to control his use. He was not going up to the second floor bathroom at his school where his friends were smoking. He was trying to stay away. He wasn't going out on weekends with his friends. And I said to him, you've been attempting to treat your quote unquote problem, your mild disorder. And, and, and I said, can you see how it might be beneficial to just have a little bit more sophisticated help, some professional help in determining how to treat your mild disorder? And the big thing is clarifying, it doesn't mean you have to get shipped off to rehab. Acknowledging that this is a quote unquote problem. I have a mild substance use disorder. It doesn't mean, that was the big news to him. I think lots of people in general, we develop different treatment plans based on mild, moderate, or severe. But when they often think, problem, crossed over a line and got to get shipped off to rehab. And that's where a lot of the resistance, but he's going to say I'm a bad person. That's where it really got my attention about, okay, that's the stigma associated with addiction in action right there. And when I got done with that session, I always ask clients at the end of sessions, what was the best thing you got out of this today? And he said, I really liked, this is the first time I'd ever done it this way, that sort of setup by showing the old model and then the new model. And he goes, I really liked how you set that up and showed the old way and then surprised us by seeing the new way. And that makes sense to me. And he ended up motivated to addressing his problem. I began working with him, and he did very well accepting the fact that he needed to treat his mild substance use disorder. I'm coming up on the end of the hour, but here's the last thing that I want to say about responsible management of substance use disorder. Remember, I said that he had been seeing an outpatient therapist for a year. And the mom did tell me that this therapist did a substance use assessment with this client. And I thought to myself when I heard that, okay, I'm impressed. A lot of mental health, especially outpatient therapists, they don't know to even do an assessment. Okay, this guy did an assessment. And mom said, he told me that he has a mild substance use disorder. And I thought, oh, okay, the guy understands. He's talking the right lingo and stuff. And then the mom said, and he said that because it's just a mild substance use disorder, we don't need to do anything different than what we've been doing with our weekly 1-hour outpatient therapy sessions, where we talk about how your week has gone, your highs and lows. And I don't know, I hope some of you can hear how I reacted to that, how I see that. He had a mild substance use disorder. The therapist knew that, and he didn't do anything about it because he didn't explain all this to that client. I explained it to him, got everybody on the same page. The parents felt validated that they knew that something's not right, but they're hoping he's not an addict and that kind of thing. And they were right. And I don't think he's a full-blown addict, and they're right in that. But to wrap this up, I'm going to give some other examples of when professionals dropped the ball. I had a girl came to me, the parents came to me, she was finishing up 8 weeks in a PHP program, partial hospitalization program, dual diagnosis program. And when I started working with the parents, and I was going to start working with her when she got done with the PHP program. And I said, so dual diagnosis, and obviously most often dual diagnosis, one of those diagnoses is a substance use disorder. And she did go in there for substance use. And And I asked the parents, I said, so what are they doing for her substance use? Well, I guess they're teaching her how to coping mechanisms for when she has urges. Okay. Have they talked with you about her treatment plan for her substance use disorder? Has the staff ever talked to you about her substance use disorder? No. And the day that she got back to school, she got arrested for smoking. It may not even smoking because she got arrested on school grounds and she got expelled. And I will suggest that again, she had a substance use disorder. It didn't get addressed while she was in PHP. It progressed. She'd never had a legal consequence. She'd never been expelled from school before, she went to PHP. Now she's got progressively worse consequences. She had loss of control because she couldn't not smoke when she got around her friends who were smoking. She experienced relapse triggers. I would suggest that a responsible way of addressing substance use is to do a relapse prevention plan. We'd be talking about, is it smart to be hanging around people who are going to be smoking? None of that occurred in that PHP program. And again, you can see very harmful consequences as a result of that. I'll give another example. I got a call from a mother. They paid out of pocket for their son to go to a 90-day dual diagnosis program. Substance use was definitely on the list of problems when he checked in. The mom called me after he'd gotten out, and he was continuing to smoke pot, and he didn't think there was anything wrong with that. And I had to ask her, did they teach you anything about they address the substance use? Well, not really. And I said to her, I remember I characterized it, it's sort of like an elephant in the room when a sort of addressed issue going through 90 days of residential treatment, and the mom's thinking, I don't think he should be smoking pot, but we don't know how to talk it. They didn't tell him not to do it in treatment. And oh, guess what? They ended up having to send him back to treatment within a couple weeks because his use progressed so quickly, and he was in another 90-day program. And I never heard from them after that program. But that's another example. And I could give you, I have lots. That's why I ended up writing that book. But so I'll wrap this up by, sort of reviewing. We talked about the importance of assessment just at the first signs. Sometimes we might be afraid of hurting their feelings, offending them. We think that you should have an assessment. When in doubt, rule it out. It's not an indictment. At least we know if there's not a problem, then we know there's not a problem. I talked about the importance of, well, we do an assessment, but then what are we going to do as far as intervention? And that case example provided a great illustration of being able to move into whatever it is that we do next. I think there's an inherent thing. If I got a problem, there's only one thing, it's all or none. I get shipped off to rehab. It's important for them to hear that, no, that's not it. But, my experience is it is so disarming. It's not threatening to tell them you've got a disorder. It used to be, we only say, you have a problem or not, you're addicted or you're not. And I think that it's so valuable learning from our history. And the changes have been, I was critical of it at first, and now I say the DSM-5 changes are brilliant. I haven't even gone into it. It offers explanations for that. This is a much more complex, and for the people who seem to grow out of it or go through periods of use and they grow out of it, it's because it's on a spectrum. It's not a black and white dichotomy, but that provides explanations. And then we talked about creating motivation is going to come from understanding. If you understand that your brain has changed and you never know when you might be triggered and your brain might kick in and tell you it makes sense to go ahead and use. And if you realize that it's progressive, and there's also a thing about progressive, you tend to pick up where you left off if you go for a period of abstinence, and it was bad enough, I don't want it to get any more, and I can't trust my thinking at certain times. I need to have a good plan in place to protect myself. That's what motivation is. And then again, we reviewed this. I think this is one of the biggest important things to teach here in that therapist that didn't do anything with this client that I worked with. I think that there's a tendency. I hear therapists say this all the time. I was in a meeting with a treatment team of a dual diagnosis a primary mental health adult program a couple of weeks ago. And the clinical director, because I was saying, you probably have some patients that have substance use issues, right? And I was saying, what do you do with them? And the clinical director, he says, yeah, we have a lot of clients where there's a little addiction. And I didn't stop him and say, whoa, let's talk about how misinformed that is. He used the term, well, yeah, there might be a little addiction. And you see now where I come from, there's no such thing as one little addiction. I don't even use the term addiction anymore, but little, again, so shows people's thinking. I think he's not alone in this. There still is this idea of this black and white dichotomy line that you cross over, and they think that we don't need to do anything about it. And so that's my main message, and especially dual diagnosis programs, to make sure we're being responsible with the substance use disorder part, even if it's mild, because it probably is going to be mild, and having a respect for us as professionals to make sure we're responding to that appropriately. Okay, let me just wrap this up. I'm going to put the link to this book if you want to download this ebook. I'll put this in the chat. That should be there. jimsavage.net/ebook if you want to download that. And then what else do I have here? My Prevent program, you can learn more about that. I work with teens, young adults, doing assessment and taking them through this 5-stage process. If you want to learn more about that, if you got clients that you would like to have do that, or if you want me to do some training with you on how to be able to do that, I'd be happy to do that. And there's my contact information. My website's jimsavage.net. So with that, I'm going to officially wrap this up, and thank you for being here. And I'm going to stay on a little bit longer here in case anybody wants to type some questions into the chat. But for our replay, video, that I'll have this up, and you can, and I'll make this replay available. I'm going to sign this off right now. And so thank you so much for being here. I hope that you got something out of it. Let me know what you got out of it, and we will see you soon.